We will present the consolidated guideline for diagnosis and treatment of multi-resistant TB. What we see in this slide is a great number of guidelines that have been issued since 1996. I would like to underscore that whereas at the beginning it took 4 to 5 years to issue new guidelines, the previous guidelines of the WHO are of not 2019 and the new ones are 2020. So in 1 year there has been a need to generate, because new evidence has been generated, so there was a need to actually publish new guidelines. This is an important challenge for the experts as well as for the countries in order to adapt to these changes. There are 4 documents that I will base this presentation on. There is one guideline for diagnosis and another one for treatment, and there also are operational manuals. The guidelines have recommendations based on evidence and the degree of evidence that exists worldwide through the grade scale. And in the operational handbooks, they explain how to implement these recommendations. With regards to the diagnosis, a key element now is that the initial diagnosis in children as well as in adults of pulmonary TB must be done with molecular methods. The expert recommendation as an initial test for these cases of TB and also for the initial detection of resistance to rifampin. Similarly, we have the Expert Ultra, which is a new generation of these molecular tests, which also has been recommended as an initial test for all patients who have signs and symptoms of lung TB in children as well as in adults. We need to mention that besides the sputum samples, we nowadays have nowadays the expert is recommended for gastric aspirate, nasopharyngeal aspirate, and in stool. The expert ultra is recommended for nasopharyngeal aspirate. The expert as well as the expert ultra are tests that have been validated for the diagnosis of TB meningitis, i.e. in the study of CSF. Next slide, please. It's important to mention that besides the cerebrospinal fluid, the expert and molecular tests can be used for other aspirates and biopsies of lymph nodes, as well as pleural fluid, peritoneal, pericardial fluids, synovial fluid, and urine. So the extrapulmonary TB also should have the initial diagnosis made through the molecular test. As to the expert ultra, it is also indicated for lymph node biopsy and aspirate. The expert ultra in general can be used for the diagnosis as well as for the detection of rifampicin resistance in extrapulmonary TB. The other important element is that when there is a disseminated case of TB, it is possible to use the expert for the diagnosis in blood for this type of TB. It is not recommended to repeat the expert in children in areas of low prevalence. It is recommended, however, to repeat these expert tests in children when the environments are high prevalence in sputum and gastric fluid, as well as nasopharyngeal, aspirate, and stool samples. It is recommended to repeat expert in children in areas of low and high prevalence for the tests of sputum and nasopharyngeal samples. not only the expert, but also the WHO is validating other tests as well, and has validated one of them, molecular test, the TrueNat test. And that test is already recommended as an initial test for TB, as well as for the detection of resistance to rifampin. This reinforces then the armamentarium that we have for molecular tests. Key recommendations for the diagnosis that continue to be present: LPA can be used for study of resistance to rifampicin and isoniazid, A2, the first of the first line drugs, but also LPA can also be used instead of the phenotypic test for the diagnosis of resistance to fluoroquinolones and of injectable drugs. We need to mention that it is not a recommendation to use injectable drugs, but many countries are in the transition towards oral treatment right now for multi-resistant TB. As to the therapeutic component, there are several aspects and recommendations. Recommendations with regards to the type of treatment used depending upon the type of resistance found, and also recommendations as to the management of patients and how to support them to improve their adherence. There are recommendations in cases of HIV co-infection and also other recommendations regarding patient-centered recommendations. So summarizing the recommendations, the first one is that in patients who have monoresistance to isoniazid that are not rifampicin resistant but are resistant to isoniazid, the recommendation is to add levofloxacin for 6 months. Combination of rifampicin, ethambutol, pyrazinamide, and replacing isoniazid for levofloxacin. In none of these cases, it is recommended to use injectable drugs for the treatment of these patients. So for mono resistance, the treatment is completely oral. The oral regimen, that is a shortened regimen for rifampin resistant and multi-drug resistant, the WHO is recommending a treatment of 9 to 12 months duration for eligible patients with bedaquiline, patients in whom the resistance has been shown and who have not received these new drugs such as bedaquiline for more than 1 month. So these we expect will be sensitive to these new drugs. There also are oral longer treatments for our MDR-TB. In those cases, at least 4 anti-TB drugs are recommended during the initial phase and followed by at least 3 drugs for the continuation of treatment. These 4 drugs are the combination of Group A drugs and 1 drug of Group B. Occasionally, if the country does not have available certain drugs or if the patient has adverse reactions to some of the drugs, the other drug of Group B can be used, or also Group C drugs. Always remember the recommendation of at least 4 initial drugs. There is a treatment regimen for patients who, besides MDR-TB, have an additional resistance to fluoroquinolones. In those cases, there is enough evidence to recommend the treatment of 6 to 9 months with 3 drugs, bedaquiline, pretomanide, and linezolid. But this must be done under operational research because still the evidence is limited. So, and this is only patients infected with HIV, so strict operational research conditions must be met. As to the follow-up of treatment in patients with drug-resistant TB, the recommendation is to introduce a culture for follow-up of the treatment in these patients. And ideally, if possible, it should be done monthly. A key element is that besides the bacilloscopy, the recommendation is to carry out cultures in a periodic manner in patients who are receiving treatment for multi-drug resistant TB. The beginning of treatment in patients who are co-infected with HIV, for them, the recommendation is to begin treatment for TB and as soon as possible, the treatment for with antiretroviral drugs, and regardless of the viral load of those patients, ideally the first 8 weeks. The recommendation is rapid beginning of the treatment for TB and as soon as possible, the beginning of HIV treatment. As to surgery, the recommendation is in patients who have MDR-TB, the elective partial pulmonary resection may be used, either lobectomy or um, the special resections, wedge-like resections, always accompanied by a treatment regimen recommended for TB MDR. This can help in the success of treatment with drugs. As to care and support for patients, a key element is the educational aspect. The evidence shows that patient education and also healthcare personnel is helpful to the adherence and treatment success. Also, various interventions can be combined to improve adherence, digital treatment, for instance, and support for transportation or supplemental food, support, and education for healthcare personnel. All these elements combined are very helpful to improve adherence and treatment success. Regarding care and support of patients as well, the evidence also shows that treatment directly observed, performed by trained personnel is more effective than and has a higher success rate than those who are in healthcare centers or treatments that are unsupervised. The treatment that is directly observed by video or phone calls is as effective as the directly observed treatment, and also that is done by trained personnel. But it does require that healthcare personnel as well as the patients have, of course, the telephone and connectivity necessary to achieve that. It has shown to be a very effective tool in order to improve adherence. Two key messages here. One is the importance of ambulatory treatment instead of hospitalized patients in order to improve the treatment for patients. And the second message is to try to decentralize treatment and to bring the treatment close to patients. In some countries, MDR-TB is treated in a single center, and that is difficult because there may be patients living in rural areas need to um, travel to the capital. But the idea is that treatment needs to be as closer to the patient as possible, and it also has to be an outpatient treatment if the conditions of the patient do allow for that. As to the program implementation, many changes are required. Among them, we need to update the policies for TB and drug-resistant TB in the countries. National strategic plans for TB, diagnostic algorithm will have to be updated, as well as treatment guidelines, list of essential drugs, because there are new drugs that need to be included, purchasing and management of the drugs, training materials, implementation of active pharmacosurveillance, pharmacovigilance, and the information systems also need to be changed or updated. For this, we require the support of the national and subnational committees of MDR-TB in implementing these guidelines. They can contribute to the changes in policies and activities related to the introduction of the new guidelines. They also can support the training of healthcare personnel in implementing the guidelines. They can also um, improve the development of interventions in patient support and have clinical advice and provide clinical advice in DRTB. As to the information systems and electronic reporting, the quality of the data needs to be improved, as also the communication between the uh, information regarding results, regarding treatment administered and results, active pharmacovigilance for the registry of adverse reactions to drugs. If possible, the FAVIA-TB tool has to be used, and drug management, if possible, using the QuantTB tool. It is a little bit more complex with the addition of COVID. We've seen the problems that we encounter to acquire the supplies and drugs, so a better drug management needs to be implemented. And I would like to thank finally the organizers for this opportunity of presenting to you the diagnostic and treatment guidelines of multi-drug resistant TB. And thank you for your attention.